Hi, and welcome to the show. Subscribe at kevinmd.com/podcast and get CME for this episode by clicking on the CME link in the show notes. Today, we welcome Maryal Concepcion. She's a family physician. Today's Kevin MD article is Bridging Care and Culture, a Filipino doctor's journey in direct primary care. Maryal, welcome to the show.
Thank you so much. Happy to be here.
So let's start by briefly sharing your story and journey.
Yeah, well, again, I'm so happy to be here. It's an honor. There have been over 5 articles just on direct primary care on your platform in over the past year, I believe. And so it's wonderful to join even a fellow Filipino doctor, Dr. Grace Torres Hodges, who was previously on your show. I am a person, like I put forth in my article, who grew up in a society filled with all of my Filipino cousins and aunts and uncles, and everybody is related by blood at some point. And what I really loved that I didn't recognize until I was away from Sacramento was that everybody was there to help each other succeed in whatever you were doing, whether you were a teacher, whether you were a lawyer, whether you worked for the state. Everybody was, everybody contributed to a place where you could, express your wins, your struggles, and we would work things out together to help everybody succeed. So that's what was represented when I used the word collectivist in my article during Asian American Heritage Month.
Excellent. Well, tell me about your practice. What's it like?
Yeah. So I practice in rural Northern California. I have a micropractice, meaning it's myself, my husband, who's also a family physician, joined in September of last year. And we have a virtual assistant, and it's just the three of us running our entire clinic. Our clinic is a direct primary care practice. Thus, my mentioning the DPC model on your platform earlier. And this is a model that both my husband and I went to after being employed by a corporation for almost 6 years in my case and a little over 8 years in my husband's case. Something that I did not really get into in the article was that my journey into direct primary care was somewhat of a ripped Band-Aid feeling journey. My employer at the time was saying that I needed to, sign a contract, which I did, put the details on in the article, where there was, a very big lack of transparency as to reimbursement rates,
Mhm.
where, if I worked for another company, they would own my money, all of these issues. And the proposition was you either sign our contract or be fired. And so I was completely dumbfounded. I had not been prepared in residency nor in medical school or any part of my training to think that a physician would not be valued by their employer. And I also only knew about being an employee at the time. And so branching off into my own clinic, my husband joined after I'd opened, was definitely, again, that Band-Aid being ripped off feeling. But we are successful because this model proves over and over again that no matter where you are in the country, this model is a successful way for patients and doctors to develop a relationship and save money and get better care all around.
All right. So you talk more about that journey in your Kevin MD article. For those of you who get a chance to read it, tell us more what it's about.
Yeah, so the what I'm highlighting, especially because of being a Filipino doctor, growing up in that collectivist society, like I explained or like I shared, DPC really embodies the way that the things that I loved about my family and growing up in Sacramento as I did in the medical field. So when I say that, what I mean is that direct primary care not only allows me to be there for my fellow physicians who have chosen or who are thinking about DPC, but it also allows me to build that relationship with my patients. I had this 16-year-old in my clinic in residency, and she had Medi-Cal, but it was so sad. She passed away from a very rare gastric cancer. But the entire time that I was taking care of her as a resident doctor, the mom was so suspicious that I was giving her suboptimal care because she had Medi-Cal. And now I'm able to say, I don't care what insurance you do or do not have. I encourage someone to have insurance for, for issues that are requiring insurance, hospitalizations, surgeries, emergencies. But for me to be able to have the time I need with each patient, and that's individualized by their needs at the time, it's amazing. And so DPC to me is that collectivist way of practicing medicine. And I am so glad that I know about it now. Clearly, I talk about it every week on my podcast, but I wish that this was something that somebody had told me earlier. I
Mm.
just went into family medicine assuming that people would be like the attendings that I saw in training, very supportive, very passionate about full scope care. but that's not what I saw when I went into employed medicine post-residency.
How did you find out about DPC?
Yeah, so it's so crazy and sort of sad that for about direct primary care, that I learned about direct primary care from an orthopedic surgeon.
Mhm.
This orthopedic surgeon was so burned out and tired of the policies like, that's nice. It doesn't matter what kind of material you want to use for your hip replacements. We're going to get these in bulk, and this is what you have to use. And this orthopod left the system in terms of branched out from the corporation that we were both working for, opened our own clinic, still thriving to this day. But that's how I learned about direct primary care. And this is why, I love to point out that direct primary care, that collectivist feeling not only is pertinent to primary care, even though that's
Mhm.
the legal term that is, in the ACA and protected in many states, but it is a business model. So we see specialists all over the place, cardiology, rheumatology, dermatology, GI, surgical specialties who are choosing to do a direct model, even if it's not their full way of delivering care, they're still able to bring an option to their patients and cut down costs and increase accessibility.
Now, we talk about direct primary care several times, like you said, on the show and on my blog. For those who aren't familiar with it, give us a 30-second description of what exactly direct primary care is.
So I have a little cheat sheet because this is the opening to my podcast, but direct primary care is an innovative alternative path to insurance-driven healthcare. And so what that means is the patients are investing in their doctor directly. And so the doctor is enabled to then feel, one, valued, which is something that a lot of physicians do not feel these days. And then secondly, they're able to look at their clinic and make sure that they're doing the best type of medicine, giving the best accessibility possible for what works for their life. Like if they have little kids like myself, that means I don't work 8 to 5, 5 days a week, but you get to craft your own way of delivering care because at the end of the day, your patients are buying into what you're bringing to the table. And for me, that is just so rewarding compared to the system that I left where, the random admin who's not even in clinical medicine whatsoever, nor clinically trained, nor with any degree in clinical medicine, is saying everyone must have an A1C of
Mhm.
7.1. Now it's I work for my patients invest in me, and I take care of them because that is that's the value proposition that I'm bringing to the table.
Now, you were at a traditional employed model, like a lot of primary care physicians were, and you were up against a lot of the obstacles that they have to deal with, whether it's metrics and EMR and administration. So you heard about this direct primary care model. It did appeal to you and your values. Tell us about that transition itself. How difficult was it for you? And tell us some of the challenges that you faced transitioning from that employed model into something that is relatively new and innovative.
So, this is a great question and something that I get a lot, especially from residents and medical students who are considering doing DPC in the future. What I will say is that the number one challenge is just healing from being an employed physician. I
Mhm.
think that, you go into thinking that, I am valued, and then you get beaten down. That was definitely the case that I experienced, and many of my colleagues who do DPC have experienced, where you really lose your sense of value. And then we, very often forget when we're going into the entrepreneurial space, we went to doctor school. That means we have a lot of smarts under our belt. And that means we can be entrepreneurs. And so that was, I think, the biggest thing that, some people say mind shift change. For me, it was just recognizing that I could do this and that, doing things that are hard is definitely possible. We all went to medical school. Opening a business there's steps. It's very much more formulaic versus, all of the things that we went through in medical school. And so the transition, I definitely would say, was a little bit different for me because I knew that I was going to do DPC before I left. And so my runway in terms of financially preparing, in terms of doing my research was definitely longer than some people's. Some people have 6 days to transition, some people
Mhm.
have years. And so for me, knowing that I had spoken with many direct primary care doctors from, all over, people who had just opened, people who are preparing, people who have been in practice for 5, 10 years, that allowed me sort of like a crib sheet to open my DPC. So I started with very, very low overhead. I had a home visit and telemedicine model only. And
Hmm.
so that allowed me to not have to pay rent upfront. And within 5 patients joining my practice, I was in the black. And so I say that just to point out that direct primary care really is, you need to show up as a doctor. And however that manifests in terms of space, in terms of access, that's up to you and what your patients value. But you do not have to invest a ton of money and resources into opening a direct primary care, especially nowadays when, there's so many people who have done it in every single state in this nation, that there are resources a lot more plentiful now than there were prior.
Now, you mentioned that you had a lot of mentors and you talked to a lot of other DPC doctors. How did you find them? Was there a website with resources? Did you listen to podcasts? How did you find these mentors before you actually transition yourself?
Yeah. So I was a person who, once I found out about direct primary care, I like to say that it's like Neo and taking the red pill. I went to every single conference that I could
Hmm.
because I met people in person. And from there, I was able to hear stories. What I realized, though, at the time was, yes, there were books, and yes, there was a podcast at the time that's no longer in production, but I was left with, I want to know more. I cannot get enough of this. And so that's where I created my own podcast, where I am active on the direct primary care Facebook groups for physicians. I try to be as present as I can at every single conference that is direct primary care focused or related, so that I can continue meeting people, because it's through networking with others that I've, highlighted on our podcast, or on my podcast, the different ways that people are delivering care.
Hmm.
And by doing that, by talking with people, not only does it make me think about DPC differently, but when I hear a person asking me questions, I'm able to direct them to these different models of how people are delivering direct primary care. And that's, to me, my podcast is called My DPC Story for a reason. It's the stories that I really clung on to when I went to conferences. And this is what I'd like to highlight, the stories of DPC doctors all over the country.
So I believe that you practice in a relatively rural setting. Is that correct?
Yes, it is.
So talk about that intersection between direct primary care, that model, and how it fits rural healthcare.
Yeah. So the rural setting in particular is so in need of quality healthcare. Unfortunately, in our area, the nearest emergency room is 45 minutes one direction or 45 minutes the other. If you are pregnant, your options for seeing an OB are very limited. Since 2015, my husband and I have been the only physicians in the entire county to offer obstetric care. That is so sad. We're in California. People don't assume that there's places this rural. We don't do deliveries any longer, but we do provide obstetric care. We provide care to the entire, span of a person's life, from, prenatal care, newborn, all the way to in-home hospice. And so in rural America, our patients, no matter how old they are, our average age is around 46. That's what I found yesterday. But my patient panel in particular, compared to my husband's, definitely swings older. And all of our patients, minus a few, have insurance. Sometimes most of the time, they have double insurance, Medicare plus, a
Mhm.
supplement. But what they find is that, one, they want a physician. That absolutely matters, because especially our older patients, they recognize the training difference of a physician compared to a non-physician provider. The second thing is that, in terms of accessibility, when your nearest urgent care is 30 minutes away and it's only open, I think it's like 8 to 4, 4 days a week, that really limits your options into how to get care. And so, as we've seen with multiple DPCs all over this nation, when you not only have access and your doctor knows you, that's what our patients tell their neighbors and their friends. And that's who we've seen this crazy uptick in direct primary care, in patients joining onto our practice, because they're like, wait, that's an Arnold? I want that. And there's even data out there to show that it's not only, I know you asked about rural, but just to put a point here, that if you are a company who has employees, even in a rural setting, you can offer these services to your employees. We've seen an uptick. There's one set of data that shows between 2018 and 2022, an over 800% adoption of direct primary care centered plans in this country.
So have you noticed any headwinds from local hospitals or traditional physicians who push back against your model? Any opposition to what you're doing in direct primary care?
Yes, and when you say that, it's like I immediately envision Star Wars. It's like there's always going to be good versus evil. But to me, that what I focus on is that DPC is growing like wildfire. There are DPCs opening left and right in all different states, and that is because physicians cannot stand when they're being devalued, and physicians are clamoring for a way to not only take care of their patients in a better way with more time and more access, but also to have a model that allows them to do whatever they want. If they want to do musical theater, great. If you want to have a bookkeeping business on the side, amen. But we could not do that, as a group in the employed model. And so, yes, there are people like in California, the data from the California Academy of Family Practice shows 86 to 90% of residents go into employed medicine. But magically this year, I'm going to be doing a talk at the state medical student and resident conference about direct primary care because the ask is out there. The I need to know what my options are is being demanded. So no matter what system exists today, for me, I focus on what's the system that is better for all of us, physicians, non-physician providers, and patients, and what can we do to optimize what we're doing going into the future. And we see that just right now, there's more bills about direct primary care that are live on Capitol Hill than any other primary care model. We also see that this is a time where, we've had calls into the investigation into private equity from the Federal Trade Commission, Department of Justice, Health and Human Services, and then, with the Department of Homeland Security jumping on the boat because private equity is affecting emergency rooms. I mean,
Mhm.
we're at such an amazing time in healthcare, and this is where I encourage people to know what are the options out there. And it's so much easier again because there's so many of us doing it, doing direct primary care as a primary care or business model that, it's easy to find a mentor.
Now, are there any types of physicians who may not be a good fit for direct primary care or that you would advise against going forward to direct primary care?
So maybe 3 or 4 years ago, I would have said it would have been harder for people to go into DPC if they weren't entrepreneurial in terms of they wanted to open up their own business. Now, I'm so excited to say that that's not an issue. There's so many DPCs that if you don't want to start the business, if you don't find that exciting, that's okay. You don't have to start a business anymore. You literally can pair with another direct primary care doctor. And that doesn't even have to be in the same building. You can pair with another DPC doctor in the same state if you're licensed in their state and offer just a telemedicine branch of their DPC. When it comes to the physicians who this is not for, because it's such a global question and it's a fair question, there are more hesitancies when it comes to surgical specialties. But again, there are surgical centers that are only cash pay in this country and they're growing. They're small, there's a small number, but they are growing. I went to a locums conference in Las Vegas earlier this year, and nobody in the room was a primary care doctor except for myself and another pediatrician. And everyone was like, wait, I could do a DPC branch of my surgical specialty or, said blank, fill in the blank specialty. And so,
Mhm.
what I think, so when, I think about the physicians who it's not for, if a physician is if they can look at their job and they can say, yeah, I'm totally fine not rocking the boat, staying status quo, getting my, 401k, my salary, whatnot, that's great. But I do say also that those people, I do recommend taking a look and making sure that medicine is still allowing you to be you. If it is not allowing you to be you, and again, those you can be a very vague thing because everybody has different interests and hobbies and everyone's at a different stage in life. But if your career is not allowing you to be you, then I would encourage people to look into direct primary care.
What do you say to those residents who have hundreds of thousands of dollars of student loans and they may be tempted by the allure of a guaranteed salary and an employed model? What do you say to them if you're trying to introduce direct primary care to them versus a traditional practice?
So what I say is and you'll hear this in direct primary care, that those are the golden handcuffs. I was just watching yesterday a person who makes chocolate structures and he was spray painting the chocolate with gold spray paint. And to me, that's exactly what these things are. When you get a 7-year mortgage paid, it's amazing. But at the same time, if you're expected to see 40 people in a day and you don't have time for you are not showing up as the best person you can at home for your family, it's the pros and cons, and you have to balance those. What I will say though, for residents and medical students, especially because of where we are in the DPC movement, is that once you are recognized as a board certified physician, you can start your DPC. So there are multiple people on my podcast who have opened while in residency. And I even have a series of interviews where four different people, family medicine, pediatrics, and internal medicine examples, have shared their story while preparing right after residency, year one, year two, year three anniversary, and this year will be year four anniversary. So to those people, I say DPC is definitely a way to earn a living, to earn a decent wage so that you're not having to think about money. There are different ways to do it. And I think that medical students and residents have a much bigger advantage compared to somebody like myself in my 40s, because they have the ability to learn and explore DPC earlier on. So creating that financial plan is definitely something that is doable. Whether you take side gigs, whether you take side gigs in DPC or in urgent care, whatever it is, or just, look at how you are investing your money differently. When you have more years under your belt,
Mhm.
you have a greater runway to prepare.
We're talking to Maryal Concepcion. She's a family physician. Today's Kevin MD article is Bridging Care and Culture, a Filipino doctor's journey in direct primary care. Mario, let's end with some of your take-home messages that you want to leave with the Kevin MD audience.
So, to the audience, what I would say is that I have truly flourished in direct primary care, not only as a doctor, but as a person. There are ways to do DPC in a nonprofit model, in a for profit model, in a big group, in a micro practice with no staff. The options are limitless. And so, if what I'm speaking to and the other doctors who have been on Kevin MD, whether in the blog or on the podcast, have shared their learn about direct primary care. There are so many options on Facebook, there are conferences. I definitely would say go to mydpcstory.com. On our resources page, you'll find all the DPC focused conferences and plan your year around them. But learn and know that you are valued as a physician. And this is a model of care where no matter where you are, you can create a collectivist society around you because that's how patients and doctors end up being in DPC, supporting one another so that this model can flourish.
Mario, thank you so much for sharing your story, perspective, and insight. And thanks again for coming on the show.
Thank you so much for having me.